So, patient concordance and motivational interviewing. This is from a tissue viability perspective, but actually there are some very common themes and so much transferable stuff to other areas. So I hope that you're going to find it's sort of helpful in that. So concordance, I'm sure we all understand now, it's a concept that's been around for quite a while, why we talk about compliance and concordance and the differences between, with the emphasis on concordance being it's about the decision making between us and the patient, really, instead of us telling the patient what to do and them just doing as they're told. It's about the relationship and the decision making between the patient and the provider to try and achieve treatment outcomes. So it's meant to be a win-win thing. So you actually achieve the outcomes that you want, but it's more win-win rather than just blind obedience. And key to this is the therapeutic relationship that you have between you and the patient. This is about relationships and communication and all the things that sort of go around it. Okay, so key things in the relationship that are important for gaining concordance. It has to be patient-centred. This is the whole point of it, really. This isn't about us telling people what to do. It's about working with them. And key to that also is patient choice. An acknowledgement that this is the patient's life, the patient's body, the patient's wound, the leg, whatever, and they have the right to listen to what you're saying or not. And so it's ultimately about their choice, really. And what you're trying to do is to have some joint decision making and care planning, so you get that win-win. Key to it, you have to have a level of understanding on the patient's side, and you are educating the patient so they're able to make an informed decision, an informed choice about their care. You can't do that if you can't listen properly and acknowledge the person's point of view, their concerns and their wishes. And so ultimately there is negotiation that is involved in here. It's not all about you getting what you want to be done. This is about you saying, I think we should do this, and the patient saying, yeah, but I can't cope with that bit, and you're negotiating a way forward. And ultimately, of course, all of this requires flexibility and, in my experience, a lot of creativity to find mutually agreeable care options. Okay, so thinking about a wound and the impact that wounds have on people's lives. So there's so many things that are impacted in somebody's life when they have a chronic wound. Such a negative impact it can have on all aspects of people's lives. Physical aspects, pain for sure, we all know that. Restricted mobility, reduced appetite, lack of sleep, fatigue, nasty sort of vicious circle that ends up having lots of psychological effects too, anxiety and depression, frustration and anger. I met a gentleman this last week who was in his 40s. He'd had leg ulceration for the last 12 years. He changed to a new surgery because of COVID. He'd had to move, and he was very frustrated and angry about the failure of people in his new surgery to understand his condition and to be able to sort of adapt around him. And the referral I got was, oh, be careful, this man, he's aggressive. We've had a few issues with him. He thinks he knows what he's talking about. He knows all the medical terms, and he's been very difficult to deal with. I found nothing difficult to deal with the man apart from somebody who was utterly fed up with his situation and dealing with people who didn't understand what he'd had to cope with over the last 12 years, including taking a year off work to stay in bed because he was told elevation was the right thing. All sorts of problems. He had a lot of pain, a lot of frustration and anger, all of it feeding into him being labelled as non-concordant because he was struggling to cope with people who didn't know what they were doing. Big social impact on things, so avoiding social contacts due to odour. I've got a video to show you a little bit later on. Now we've worked out how to do that. To exudate, the stigma around it, low self-esteem, difficulty holding down employment. I've met a number of people who've had to leave their jobs and been unable to work because of a chronic wound, and struggling with increased dependency on sort of family and friends. And this is not just, you know, little old ladies. This young man had to have a year of being unemployed because of his wound. So massive impact that they have on people's lives. I'm going to move on to talking more about compression and concordance, but a lot of this is transferable. As I said, we could be talking about somebody with a pressure ulcer here, very similar sort of things, and we could be talking about any person with a chronic illness, and things that you are asking them to do. So I'm looking at some of the evidence around compression and presenting that, but you know, a lot of this is sort of transferable in many ways. So venous leg ulcers, compression and concordance, what do we know around that? Well, we know for a start that compression works. There's a lot of evidence around it, that when you've got a venous leg ulcer, that is the treatment for you. We also know from the evidence that it is underused, that not everybody with a venous leg ulcer has you know, 40 millimeters of mercury on all the time, and that non-concordance is very frequently quoted as a reason for patients not having compression on. It can be really significant when you look at the studies that look at it. Studies that were part of like a randomized controlled trial, so had more control and patients sort of had more active sign up to it. They had up to 40% of non-concordance with compression in that. But in real life studies, the evidence is that up to 80% of people struggle to concord with compression therapy. And this is a really negative impact on their outcomes, with decreased healing rates and increased ulcer recurrence. And again, if you would look at the information on pressure ulcers, you know, you'd have increased rate of pressure ulcers, longer lasting pressure ulcers, yeah, and poor healing rates with them as well, for the same reasons of not being able to concord with things that they were advised. So what are the reasons for non-concordance with compression in particular? There's been some, Christine Moffat back in 2009 looked at all the evidence to say, well, why aren't patients wearing their compression? So some of the things that we've already mentioned, and this photograph here is just sort of, you know, typical really. You can just look at that to see, you know, you can see how painful that would be. You can see how wet that would be, how much, you know, that exudate on the skin. It's not just water. Anybody else sort of sit in the bath and you can't sit there too long because it's just too irritating when your fingers start to go all creased? Well, imagine having that exudate all over your skin for days on end before you had to go back and have your dressing changed, and how irritating and uncomfortable that would be. You know, concording with sort of stockings, how difficult it is to get compression stockings on. You know, my mum, lover, 84, has got a degree of heart failure, like a lot of people of that age do. You know, she's got a slight tummy, she's quite short, reaching her feet isn't the easiest of things, but reaching her feet and having to exert herself whilst she's down there. So although she can do it, it isn't half a difficult job. And I can see that there are some days when she thinks, do you know what, I just can't cope with doing this today. Patient education. If you, oops, a daisy, sorry, let me go forward. If you don't understand the importance of the compression, then you have less of an understanding about why you need to sort of keep it on. And so the things that you are struggling with, you are far more likely to cave in and go, oh, I'm not having this, thank you. So patient education is really, really important. How can you make a decent decision about something if you're not fully armed with the facts? And it's not just that, well, you've got venous disease, you need to elevate your leg, this will help it heal. But it's all of the, you know, the potential consequences of not, and how things sort of can pan out. So, you know, people perhaps who haven't got a leg ulcer, and you're saying, look, you've got nasty venous disease and swelling. If we don't do this, the risks of you having an ulcer in the future. So trying to educate patients so that they're able to make a decent and informed decision, important. Psychological factors as to why people don't concord with compression might be a poor relationship with the healthcare team. So again, the gentleman that I was sort of like talking to doesn't have an awful lot of trust in the people that are seeing him at the moment, and he's far less likely to do what they suggest by, you know, if they sort of saying, well, you should have this bandage, he's like, well, I've had these bandages before and that one hasn't done any good, I want this bandage. Those sorts of things. A poor relationship can make it very difficult for people to concord sometimes. Poor social relationship and additional life stresses. I know what I'm like when I've got far too much going on. You know, my own health sort of stuff, I really need to go on a diet again, but it has been such a busy and stressful summer. There's been so much going on that I just can't cope with it, and it's waiting until some of the things have moved on before I am now prepared to be able to deal with going on another diet. And it's the same with our patients and the things that we're asking them to do. Sometimes it's all just a bit too much, and it's more than they can cope with. Then there are aesthetic and cosmetic factors why people don't wear compression. I love this picture of Nora Batty. Those of you who are young possibly won't remember Nora Batty, but you know that there are the generation that's out there when you suggest these stockings and they go, oh my God, they're Nora Batty stockings. You know, they're none too sexy to look at, particularly if you're looking at younger people. I've got, you know, another lady who likes to wear straight trousers and nice shoes, and she can't get her compression on underneath it, and it has taken us a couple of years actually to problem solve that one with her, to work out how she can feel nice in her clothing and still have her compression on. You all know the problems of getting footwear on and showering, and how difficult people find it to cope with not being able to do those things. And then there's the economic factors and the factors around us that make a difference around patients that are concordant. So, you know, are we using certain products that might help them to concord, or not using them because of cost, when actually if we did use them, I mean, I'm thinking particularly in wrap garments here, it's been very difficult to move forward getting the powers that be to agree to us using wrap garments, you know, on formulary because of the unit cost of them. But actually it's more cost effective if you can get people to concord, because they can manage to readjust these themselves than otherwise. So sometimes cost comes into it. You might be giving somebody a cheaper something, or only seeing them once a week, and that they struggle to concord because of that. And clinician issues, you know, a poor assessment results in you making choices and treatment recommendations that are less likely to be successful. Poor garment choice, you know, particularly with hosiery. If you've got somebody with edema and you would choose a nice soft stocking, it won't manage the edema and it will dig in below the knee, and people won't concord with that. If you've not applied things properly, it could be more painful. Bandaging, if you've stopped the bandaging too low down the leg, you'll get bulging above it and the bandaging rolling and digging in. And if you don't understand things about wound care, if you're not spotting, for example, that a wound has got too many bacteria in it, it may not have a raging infection, but it might have lots of bacteria in it, and that's causing odour and exudate and more pain for the patient, and that's helping contributing towards them struggling to concord. So there can be clinician issues as well that lead to patient non-concordance. Now, I want to just play you the beginnings of a video that Sarah Gardner did several years ago, interviewing a few patients, because there's some heartstring tugging stuff in here that really helped me understand the impact of leg ulcers on people and why they struggle not to concord with things. So I'm just going to play you a few minutes of this. Bear with, I just need to stop sharing this presentation and now upload the video, which I hope really will play. And play. Can you see it?
I'm not getting the sound again, Penny. Sorry to break it down.
You're not getting the sound again?
No.
Okay, hang on a minute. Let's just go back to let me just stop sharing one moment. I'll just try that once more. Yes, it's there. I found it. Sorry, this is my
Leg ulceration is a chronic condition affecting approximately 1 to 2% of the population. More than 40% of those affected by leg ulcers have had open ulceration for more than a year. And for those fortunate to heal, 12-month recurrence rates of between 26 and 69% have been reported, with some patients experiencing symptoms for most of their lives. Leg ulcers can be considered to be life-limiting. They result in impaired mobility, reduced activity, altered body image, and low self-esteem. Leg ulcers can have a very negative effect on many aspects of patients' lives. The European Tissue Repair Society attempted to define the term quality of life in relation to patients with chronic wounds and determined that the patient is the key to defining this experience, as only he or she can understand fully the significance and effect of his or her experience. With this in mind, as clinicians or commissioners here today, it is important that we listen to patients who are currently experiencing leg ulceration and hear exactly how this horrible condition affects their lives. This short film will provide just a taster of what patients experience on a day-to-day basis.
Hello, I'm Mark. I'm 39 years old. I've had my ulcers on my ankle/leg for 2.5 years now, which I think the cause due to my motorcycle accident I had in 1994 and 1997.
I'm 84 years old, 85 this year, and I've had these leg ulcers on and off for 8 years, these bad ones, at least for 15 years altogether. They have healed, the left leg has healed, but not the right leg, ever. And all of a sudden they break down again.
So what do your ulcers look like?
The right one is very nasty to look at, but I can look at things, I can look at people with blood, if you know what I mean, or anybody's got blood everywhere. It doesn't upset me, so I can look at this ulcer, but that one is looking great. Since Sarah's been getting the nurses to put this special stuff on, Ergo, and Ergo Start, and different things that I've never had before. And all the nurses are very good, and they do everything they're asked to do and told to do, and I don't know how they look at them sometimes, because I wouldn't want to look at somebody's legs that look like this right one.
Hello, my name is Patricia Stringer, and I've had my leg ulcers for 7 years.
Can you describe your leg ulcers for me, Pat?
They go right round my leg, sort of all the way around, and they're very sore.
My name's Michael Holness. I've had egg ulcers for the past 30 years, which have been very painful, very distressing and very uncomfortable.
Can you describe your ulcers for me, Michael?
They're on both legs. The first one was on the left leg, which started from a bicycle clip and has graduated up the leg and down the leg, right down to the ankle. For some reason or other, I got them on my right leg. How or why, I've no idea, but they appeared. And the ones on my foot are from the result mainly of when I had some wet bandages and they started to dry out. I used to rub it with the heel of my other foot, so it's broken down the skin on top of my foot. So that's why I believe that my foot, on the right foot, and the toes have broken out.
And it goes all the way around my leg, from one side to the other. It's very wet and it's got an awful smell. And it's sore and raw.
How does that make you feel?
I'm well embarrassed when it smells when I'm out.
Have you had some experiences then where that's been quite embarrassing
when
for you?
people say there's a funny smell, and I know what it is, but they obviously don't know what it is, you know, but I do.
That must be quite distressing
It
for
is.
you.
And I'm also embarrassed when it leaks through, you know, through the white bandage, because sometimes it do. And then I've got to walk up doctors like it.
Do you feel the nurses understand what you're going through and address all the issues that maybe you're experiencing?
Yes and no. I don't think they understand the pain that I'm getting with them, because they are very, very painful. It's just like putting a cigarette out on your skin. It stings.
Do you feel the nurses looking after you understand what you're going through with your leg ulcers?
Not really, no.
Can you tell me a bit more about that?
Well, you never see the same one, because they don't work my days. I go Monday, Wednesday, Friday, but Leon doesn't work Mondays. Carol doesn't work Fridays, so you're always seeing a different nurse.
What sort of skills do you think that nurses need to manage patients with leg ulcers?
Well, I think they need more, because as Leanne said, they're general nurses up there. They're not leg ulcer nurses, are they? And every time you go to the doctors up there, they know nothing. You know, if you go with something, he says, see the nurse. They know more than I do.
So how does that make you feel?
Well, they should know a bit about ulcers.
Right, guys, I'm just going to stop that there, but I hope that gives you a real taster. I don't know about you, but some of those things, when she was talking about walking up the road with the exudate dribbling out of her legs and the smell, and that man about his pain, it just made me think, you know, really, I need to stop in my working life sometimes and think about actually what this person is experiencing, why they're finding it difficult. Because in my experience, that people, you know, that there is a reason why they're not concording, and if you can get to the bottom of what that reason is, then and that's what takes the sort of partnership working and the communication skills and things to do it. Let's just go back to our sort of presentation. Okay, so what resources have you got out there to help you? Well, what are the things that are out there that can help you cope with all of this? So the key thing that I would say is doing a thorough holistic assessment. You need to know about all the aspects of a person's life that is affecting whatever the issue is. So in this circumstance, we're talking about leg ulcers, but it may well be, you know, moisture lesions, or it could be pressure damage and the like. So you need to do a really thorough assessment, because it'll be the thing that it's impacting on one part of their lives that will be making the big difference here, and you need to know what that is. And clearly it's obvious, isn't it, from all of that, that we really, really need to be addressing pain. So you need to use all the pain assessment tools and things that you've got out there to do a decent assessment, to try and identify when they're having the pain, using those descriptors to work out whether this is nociceptive pain or neuropathic pain. Yeah, and talking through what relieves the pain, what doesn't relieve the pain. So, you know, really trying to skill yourself up on how to do a decent pain assessment, and also a quality of life assessment. This you can see on the slide here on the right. There's a quality of life wound checklist that is available on our website on the resources tab. There's 2 pages to it, and it's something very simple, very quick and easy that you can get the patient to fill in themselves, just to understand how this is impacting on their lives, and that in itself will help you see the areas where you're likely to be contributing to sort of like non-concordance. You need to be educated. You need to know what you're doing. So if you don't know what you're doing, you're not going to be able to make the best advice for the patient, and they'll struggle to concord with it. So make the most of the bite-sized training that's out there at the moment. Make the most of the reps for the companies. So L&R with their hosiery and the hosiery formulary and the like. Juzo have got a thing going on called Juzo Assist at the moment. Use our website. Make sure that you are, there are e-learning opportunities, particularly L&R have got all sorts of modules that are RCN accredited, that, you know, wound assessment and the like, bandaging videos, etc. Ergo have the same, they have bandaging videos and things that you can look at. So make the most of all of those educational sort of like opportunities, and make the most of all the other resources that are out there. So again, our website, get that saved on your desktop, find it on your iPads. You'll find there's a section in there on the resources tab that's got patient leaflets that you might find helpful. Use the Ergo and L&R websites, use for compression and the like. Don't forget that there is the hosiery booklet, which is an educational resource, and the hosiery formulary. Both of those are available on our website on the lower limb tab. You scroll down and you click on compression and you will find the hosiery booklet and the formulary there. And if it's legs, of course, do use the Legs Matter page. There is patient information on there. You can direct patients to that and you can find some resources there for helping you with sort of patient education. And it's not just about those things as well. You need to be having the working processes in place that will help with patient concordance. So you saw in that video that Pat was sort of saying she never sees the same nurse twice. Things like having a named nurse and having some continuity of care will help the patient feel that, you know, as a named nurse, you'll be able to do your assessment and care planning together with the patient. You'll be able to sit down and work out with them, what are their goals? What are the things that matter? So clearly for Pat, exudate management, so that she doesn't have to be embarrassed walking up the street with exudate coming through on the bandages, odour control. But you need to be able to have that partnership working, and a structure of named nursing is important for people who have these complex wounds. Continuity of care, shared care planning, and also multidisciplinary working, you know, working alongside our other colleagues, podiatrists. You know, a lot of these people have issues with feet. I've been working quite a little bit recently with the orthotics people, people with edema, how to get compression on underneath sort of orthotics and stuff. Yeah, so there's other colleagues out there that can help you with this and getting some concordance. So there's plenty of resources out there. The main resource, the main thing to be coping with concordance, however, is your communication and interpersonal skills. It's an art form, this. There's a real craft, I think, and I think it's a very nursing craft as to how you communicate and how you relate with your patients is absolutely key to gaining concordance. And there's some key things in there. I mean, for me, this is a lifetime learning lesson of developing the skills of how to help people gain sort of like concordance. And there's some classic pitfalls that I fall into all of the time, a little bit like Barack Obama on the front sheet of, you know, just do as you're told. And I think a lot of us, when we're sort of short of time, are inclined to want, you know, patients to just accept that this is what they need to do and to do it. But you need to think about how you respond to situations like that, because for sure I don't respond well to being told what to do. And motivational interviewing is all about communication and how you communicate with your patients and how you relate with them, to do it in a way that makes the best chance of keeping them on board and then being motivated to want to work with you and make the changes that you are asking them to make in their lives. So it's how to communicate with people to get that win-win thing. And there's some key tips. Like I said, it's a lifelong thing, but there are some key things, techniques that you can take on board to start with. Okay, so there's a real spirit in motivational interviewing of you're not trying to wrestle with patients, which is often how I think as nurses we end up feeling like, oh, why don't you just do as you're told? I keep telling you to put your feet up and you won't. You need to not, if you're in that zone, then you need to stop, because you're not getting anywhere. Because when you are struggling and trying to push somebody to do something you want them to do, they will be resisting. What you are trying to do is to dance with them, not to wrestle with them. And there's three key things that you need to do. And actually for me, it's the bottom one here that makes the biggest difference. It's recognizing the autonomy of the client. This person has the absolute right to make a complete mess of their lives and not concord with what you're advising, whether it's through sheer stubbornness, like my mother and like myself, or whether it's through whatever the reason, they absolutely have the right to do that. And unless you acknowledge it, you will be pushing up against something. And once you do acknowledge it and take it on board, it actually changes the way you communicate. It changes your attitude. It changes the way you speak and the emotion in the way you speak. And for me, that's one of the key things, recognizing that everybody has the right to make the decisions about their lives themselves. Collaboration, we've talked about that. It's about coming together. It's a partnership where you give them the benefit of your professional expertise, but it's about helping them to become an expert in their own lives. It's not about manipulation. And also what you're trying to do is you're trying to draw out of somebody. You're trying to help them find their reasons for doing this. And the more you talk about it, the more you will be able to, so somebody sort of saying, oh, I couldn't do that. Okay, well, what would be the consequences if you didn't do that? Okay, and say, for example, we managed to get this healed, what would that be like in your life? So can you think of one thing that you could do towards this? So trying to draw out a client's own sort of ideas and expectations and making it real to their lives, trying to draw all of that lot out and having conversations around it gives a much better chance of getting them motivated to come on board and work towards it. So trying to get that win-win. So the aim is to sit alongside the client in order to discuss a shared concern as equals. So that is the spirit of it. And I think if you enter into your communications with that in your heart, you will go a lot further. Other key things are that there is an answer in there somewhere. They will have the solution to this situation. So how can we work the compression, blah, blah, blah. Could we do this? Could we do that? Somehow they will have an answer in there that will help. You need to believe that they are capable of making a change. And you also need to accept that it's their lives and they're the expert in themselves. And our role is to generate hope in them and to try and build up their reasons for change and to assist in any sort of action that needs to happen. So people do need to be ready and willing to change. And something that's really helped me understand this a little bit more is, when you get people that just, you think, God, why, look at the state of your life. Why don't you want to take this on board? Actually, that ambivalence of shall I or shan't I, or I know I should, but that whole but business, oh, well, yes, I understand that, but that is a really normal reaction to a very complex situation. And often people are really struggling to make these decisions. It's because they're just stuck in oh, this is just so awful. I don't know how to move forward. And you're trying to get me to do these things. And actually, it just makes me feel more anxious about it. And sitting and doing nothing is often the safest place to be ambivalent, because it's such a complex thing. And as you're trying to move it to change, it can increase the tension and discomfort for somebody. So you can, simple things that you can do to try and look at somebody's willingness to change is to do a cost benefit analysis. So what would be the cost of doing this and what would be the benefit? And questions like that will help you work out, are they in a place where they are willing to make a change? And are they ready to change? You can look at by looking at the health behaviour change cycle, which some of you will be familiar with. So the stages of change, the sort of pre-contemplation, I don't want to do it. I'm not even acknowledging that smoking is bad for me, to, okay, well, I do recognise it's bad for me and I might try it. I mean, I should try it, but I'm not quite ready yet, to, okay, I'm going to do it. How am I going to do it? I'm getting ready to try. Then the actually taking action, and then the how to make that into a habit, and how you communicate with somebody and the strategies. You need to be aware of those cycles to work out where they are, to actually target your communications and what you need to focus on. Because if somebody is not accepting that the compression bandaging is going to improve their ulcer, then that is what you need to be focusing on, is trying to help them to understand how. So where are they in that cycle? Basic strategies of communication, open-ended questions, always good. affirming and supporting the person. We're trying to build them up. You may be spotting all sorts of things that aren't good, but trying to affirm the things that are. I can see you're a strong person. Look at what you've had to deal with. You're clearly strong. I can say from what you're saying that you understand the importance of this, and those bits of affirmation help getting people on board. And then listening to people, it's that reflective but active listening. So when they're speaking to you and saying something, summarising at the end of it or saying back to it, it sounds like you find that really painful. From what you're saying, you know, you've had all sorts of different compression and in your opinion it hasn't worked. That way the person feels that you have listened to them, that you have heard them and you've acknowledged their experience. Really, really important, that one. And then summarising the conversation at the end. So from what I understand is that this and this and this is the issue. You've tried this, you've tried that, and you still are convinced that the compression bandaging is never going to help you. Right. And that will then help you sort of move forward. And you just need to have belief in there somehow that on some level the patient believes that change is possible, that it is in there within them. This is a marvellous little technique, and one I really do need to employ more frequently. Giving advice. It's called the information sandwich. It's a very simple little technique, but very, very effective. So when you want to say to somebody, what is wrong with your legs is you've got venous disease, and if we don't do something about it, this is only going to get worse, and you've got to wear compression, and if you don't wear compression, you get an infection, blah, 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 blah. If you just tell somebody that, they will come up with every reason under the sun not to go with it. Well, certainly I would do. But if you say to them beforehand, can I tell you about this? If you ask their permission beforehand, they are far more likely to listen to you. So on the bottom, the advice sandwich, would you like to know? Do you know about this? May I tell you about this? Get their permission and then give them the information, and then you ask them about it afterwards. So may I tell you at the beginning, or what do you already know? What do you understand about venous disease? You know, I can see from your leg to me that you have venous disease. Is that something that's familiar to you? Tell me what you understand about it. Okay, well, I think you understand a lot about it, but there's probably something that I'm not sure that you've completely got your head around. Do you mind if we discuss this? Once they've given you their permission, then they're going to listen to you. And at the end of it, you say, so what do you think about that? Does that change your mind, or how do you feel about that? That information is far more likely to stick where it is. So these are just a few examples of techniques. Motivation interviewing is a massive sort of subject, but I hope that you can see from that that there are some really handy hints to help you communicate and have a different way of relating with your patients to try and get a better relationship that's far more likely to sort of gain concordance. So the key things in there, you've got to do a decent holistic assessment. You have to know the impact and what the patient is dealing with, so that you know exactly what the situation is. You need to be aware that there are many reasons why people might not be able to go along with the advice that you're giving. You certainly need to be non-judgmental. You're not in their shoes. You do not know what it's like to have this sort of situation, and you are aiming for partnership. You know, it's their life. They have autonomy over their lives. You guys are in this together, and you need to develop those great personal skills. And if you get all of that, everybody will live happily ever after.